Welcome back. I'm the Intense MD, a double board certified intensivist, here to give you an inside look into the intensive care unit. Today's video is a Q&A. I got these questions from a variety of sources, so of course if you have any questions that you want me to answer in a future Q&A, those are the places where you can find me. Today we're joined by Remix, who seems to want to hang out here. I'm testing different places in my house to film just to see where I have the best lighting and audio quality, video quality. I know my audio quality is kind of variable. When I started this channel, I said when I get 50 subscribers, I'm going to buy something for my channel to increase the production and quality of my videos, and my purchase is going to be a microphone. So if you're an audio content creator on YouTube or podcaster, or just know a lot about microphones, please comment below your recommendations because I know nothing. I don't want to end up buying a junky one. I want a good quality one. So if you have any recommendations, please leave those below. But without any further ado, I'm going to start the Q&A. If your first question is, what is an intensivist? I have already answered this question in my very first video. So the first question is, what is the difference between a resident and an attending? In medical training, there is a hierarchy. First, there's the medical student who may be part of the team. Usually a third or fourth year medical student does clinical rotations in the hospital. Then there's an intern. Intern just means that it's their first year out of medical school. They are a doctor. Once you graduate from medical school, you have your doctorate, so you are a doctor. It is their first year of training. We call it PGY1, which is postgraduate year one. After you're an intern, you become a resident. And residency programs vary in length depending on specialty. I was an internal medicine resident, so my program lasted 3 years. There's an option of doing a fellowship. So this is somebody who has completed residency in a particular specialty, but they want to continue their training and focus on one particular area of that specialty. So for instance, for me, after I finished internal medicine, I knew I wanted to exclusively work in the intensive care unit, so I did 2 more years of training where I just did intensive care. An attending is somebody who has completed all of their training. So they went through medical school, residency, and potentially a fellowship, and they are practicing completely independently. They don't have anyone overlooking them. Is July really the worst time to be in the hospital? So the reason why people say this is because July 1st is the first day of work for interns. It's the day that the academic calendar for residency training and fellowship training begins. So if somebody is starting a residency, it starts July 1st. If you're starting a fellowship, it starts July 1st. So the common misconception is, well, I have a brand new baby doctor taking care of me, their first day of being a doctor, so I'm going to get terrible care in this hospital at a teaching hospital. And that's not true. Everybody knows that, these people are fresh out of medical school. And I just explained that hierarchy to you of interns, residents, fellows, and attendings. So the attendings, residents, fellows are all keeping a very close eye on these new interns. We know every year in July that we're getting a new batch in, and we're going to make sure that they have the support they need. Yes, there is a lot of on-the-job training, which is why we go through these years and years of postgraduate training, but everybody is watching them like a hawk. Why do people ignore the beeps from the machine so often? There's a couple reasons for this. So every machine has a different alarm. And some machines have multiple alarms. So by that sound, you'll know what machine is going off and sometimes even what the machine's alerting you to. The IV pumps will beep when an infusion's complete, so the nurse knows that they can take that medication off. So the nurse might hear that an antibiotic's completed, but they might not feel the need to rush over if they're taking care of something else because they know that that's just a sign that the medication's completed. It's not something that's alerting them to danger. When our telemetry monitors go off, and again, the telemetry monitors are the ones that show the heart rate, EKG, sometimes we'll already know this patient has the abnormal rhythm or the abnormality that's alerting us to. So we'll say, okay, we knew this was happening, we're already treating it. If it's a critical rhythm, we absolutely go and look at it. But in the intensive care unit, we have telemetry monitors at the nurse's station, so everyone can see what the rhythm is without going into the patient's room. If the patient's on the floor and they have the telemetry monitor in the room, there's also central telemetry, which is a room in the hospital where there are people trained to watch these monitors. So if the patient's nurse is not inside the room seeing the abnormal rhythm, there's somebody watching the monitor from a distance that will call the nurse and tell them, hey, this patient had 13 beats of VTAC, or hey, this patient just went into AFib. Do you guys live in the hospital? Like, is there a TV and shower and stuff for you guys? So I don't physically live at the hospital, although it may feel that way. There are times where I've stayed extended hours at the hospital, 24 hours or more. During residency, there needs to be a call room if somebody is taking call, and that typically has a bed. And if not necessarily within the call room, there should be an area in the hospital that's available for the resident to shower. The call rooms, it's plus or minus whether or not they have a TV. Sometimes the workrooms do, sometimes they don't. Sometimes the doctor's lounge has a TV. There are places to stay overnight and shower if needed. There have been situations where I've taken an overnight bag to the hospital and stayed and showered. Usually it's during natural disasters, like in Houston during Hurricane Harvey. I spent an extended amount of time in the hospital because the roads were impassable. So you bring a couple days worth of snacks and clothes and just plan to stay. But on a day-to-day basis, as a resident, you have a call schedule. There's some rotations where you'll stay overnight. There's some rotations where you'll stay for 24 hours, and there are places for you to sleep if you're able to and shower if you need to. How did you decide to specialize in critical care? So this is actually a longer story, longer explanation. So I'm gonna make a separate video about this, probably post in the upcoming weeks, because the answer is gonna just be a little bit too long for this video. So I got two similar questions. One was, how do you deal with the emotional exhaustion of taking care of critically ill patients? And also, how do you decompress? They're kind of related, kind of not. So dealing with the emotional exhaustion, it does exist. Taking care of critically ill patients, especially this past year, has been difficult. There was a point where I said, I feel like I'm a professional bad news breaker. I feel like every day I go to work and I don't tell people positive things, especially with the COVID pandemic. There have been a lot of situations where we've had people of all ages come into the hospital and unfortunately not recover. So you have to have these difficult conversations with the families, and there were some days where I'd be having these conversations, 3 or 4 conversations with different families back to back. So it is emotionally exhausting. I think one of the things that helped was, we're not alone. I have friends who are also in critical care who have been experiencing the same thing, my coworkers, people from different teams. So sometimes just talking to other people about what you're going through and realizing that, we're all going through the same thing, and we're all just, we're trying to do what's best for the patient. It is, sometimes it's nice to just know that you're not alone in your feelings, and you're not alone in feeling emotionally exhausted, because it is hard. In terms of decompressing, what do I do personally? So on my days off, I kind of assess to see what I need. Sometimes I do nothing, literally nothing. I'll watch TV. I love trash television. So if you have any terrible reality shows that you enjoyed, please let me know, because that seems to be what my brain likes lately. I also, I've been doing puzzles, I've been reading books, I try to talk to my friends and family who I, can't visit physically. I try to stay in touch with people the best I can. Sometimes I'm not very good at that. I play video games. I have a Switch and a PS4. I have not been blessed enough to get a PS5. They've been incredibly difficult to come by. I exercise, I try to go for walks outside. I really like to go hiking, but there aren't a lot of hiking spots in the area I live in right now. Does the hospital buy your clothes? When I was a resident, we were allotted 5 pairs of scrubs, I believe, per year. We got a link to a particular website to get scrubs that were embroidered with our hospital name on it. And we were just able to select our size and got shipped to our house. A lot of hospitals will have like a scrubs machine where you'll have an allotted amount. I know one place I think we were allowed 2 or 3 out at a time, and then you return the scrubs and it notes those as being returned, and they take those to get laundered, and then you can get some more in your size. For fellowship, we did that, and in order to graduate, the laundry room had to sign off that you returned all your scrubs. I buy scrubs from a different company because I like the way they look better. I think the material is more comfortable, so I buy my own scrubs. I don't get reimbursed for them. In my mind, it's all I've been wearing lately, so I can put some of my budget towards more fashionable scrubs. Do doctors eat the same crap as patients do in the hospital? Yes and no. I try to bring my own food to work. One, because it's more convenient for me. I don't have to be running down to the cafeteria if I'm busy. My food's readily available. I can microwave it if needed to in our workroom. I sort of count macros. So I typically bring my own food. But if I were to go to the cafeteria, it comes from the same kitchen as the patient's food. A lot of times it's the same food that they're serving that day for the patients. But there are some places where the doctor's lounge may have different food. There have been some instances where I went to the doctor's lounge and there was food from somewhere else. Doctor's Day was last week, so they had catered food from, this other restaurant. But that's not a daily thing. What do you do when you're not rounding? Are you taking naps or relaxing somewhere? Definitely not taking naps, probably not relaxing. I feel like this might need its own video too, just to talk about what my day-to-day structure looks like. I talked about briefly in my What's an Intensivist video. But no, when I'm not rounding, I'm calling patients' families, I'm doing procedures, might be looking through their chart, looking at labs, looking at micro, looking at imaging, trying to decide what to do for the day. I'm going back and reassessing patients. There's a lot of things I'm doing in my day that's not necessarily rounding. So this video looks like it's getting pretty long. I do have more questions here, but I'm going to save them for another Q&A video. Again, if you have any questions, please leave them down below. If you have any recommendations for microphones, leave them down below. And I will be back on Tuesday with a video talking about code blues.